So my name is Katie Valciukas and I'll be talking about septic arthritis today, and I'm a third year medical student. Okay, so some 5 quick sort of facts if your consultant asks you what septic arthritis is. It's an infection of the joint space. It can be either in sort of someone's native joint, that's about 6 per 100,000 people, versus prosthetic joints, which is much more common, and that's about 70 per 100,000 in the population. There's increased risks for developing septic arthritis. One of the biggest is having rheumatoid arthritis, having implants or any surgery or intervention to that joint, being immunocompromised. This includes diabetes, increasing age, skin infections, and IV drug use. There's 3 main routes of infection, the first being hematogenesis spread, so through the blood. And that can be like disseminated infections. There's direct inoculation. That's when we're talking about the surgical interventions or procedures and trauma. And then there's contagious spread, which is just from like a local area. For diagnosis, we are looking at signs of inflammation and a positive arthrocentesis. That's probably the biggest thing you need to know, is we need to do that as soon as possible. And then treatment, we can either do a surgical debridement and clean out, possible removal of the prosthesis, and targeted antibiotics. Okay, so who do we blame? So there's a couple of different culprits. The most common is Staph aureus. That's the most common in all adults and everyone above 2. And it's most often linked to post-invasive procedures, so even like joint aspirations, surgical procedures, anything like that. And then there's a couple other ones. There's this K. kingi in kids, streptococci, which is associated with splenic dysfunction. Gonorrhea is quite common. You can get gonorrhea, septic arthritis, which is associated with sexually active individuals. Gram-negative rods is often immune compromised, trauma patients, elderly, and IV drug users. S. epidermis, skin infections. H. influenza, more common in children. It used to be the most common, but now that we've got this vaccination program, that's died down a bunch. M. tuberculosis and this Lyme's disease are rare, definitely in Australia, but good to be on the eye out for. And then there's other infective arthritis. So you've also got your viral arthritis, which often presents with like a rash, and then fungal arthritis, which you'll probably see more in immune-compromised individuals. All right, so clinical features. We're looking for an acute set of pain, that classical triad of fever, joint pain, and restricted movement, so all the signs of inflammation. It usually presents as monoarticular, but given like that's still 12%, 22%, where it can be polyarticular. So just because it's in more than one joint, don't rule it out. Most commonly affects large joints, so most commonly the knee, then the hip, then the wrist, then the shoulder, then the ankle. But if you're worried that the person is an IV drug user, it often presents in these axial joints, so these really weird joints. I've got a picture in a second to show. And again, signs: swollen, red, warm, painful joints. But also if they're asymptomatic or their presentation isn't normal, that's quite typical in older patients or even prosthetic joints. So just because you haven't got all the classical symptoms, don't rule it out quite yet if you're suspicious. So these are just some fun pictures. You can see here we've got a sort of atypical axial joint presentation, and that would be associated with IV drug users. And then just some nice signs of inflammation there. So really red, really swollen, looks really painful. So differential diagnosis. So we've got all the different types of infective arthritis that you need to isolate. So you've got your viral, Lyme disease, tuberculosis, gonoccal, and fungal. And then you've got hemarthrosis, which is blood in the joint. That's more a traumatic presentation typically. We need to rule out gout or pseudo-gout. Need to rule out reactive arthritis. This is more of a chronic inflammatory problem, and will present with signs, gastrointestinal upset or other skin changes as well. Avascular necrosis and rheumatoid arthritis. So there's some of the differentials we want to be looking at. So diagnostics, like I said earlier, the most important thing that we need to do is arthrocentesis. So this is aspiration of the synovial fluid for diagnosis and also therapeutic purposes. So indications that we would do this procedure for are synovial fluid analysis, which is what the main thing we want, suspected hemiarthrosis, or fluid decompression. Contradictions. So if they have a skin infection, we definitely want to clear that up before we do this procedure, because we do not want to be spreading more sort of microbials into the joint and leading to an infection if there wasn't one already. However, though, we if that wasn't there, we want to do this as soon as possible, because the sooner we diagnose septic arthritis and start treating it, we can prevent cartilage damage from inflammatory process. So this is an acute sort of issue, an emergency issue, as we were saying earlier. So findings. So there's a couple of findings that we'll be looking at in the joint aspiration. So first, the appearance. Instead of being that nice, clear sort of fluid, we're going to get this yellow-green turbid appearance. That's sort of indicative of an infection. We're going to have, when we do some tests, such as the MCS, gram stain, crystals, cell count, and some PCRs, we're going to find an increased white blood cell count with neutrophil predominance, especially if it's a bacterial infection. White blood cell counts can be lower in prosthetic septic arthritis, so that's just something to be aware of. We're going to find lower than blood glucose levels due to the bacteria being really hungry. We're going to have a positive gram stain, as in we're going to find bacteria, not that it's gram positive. And then we're going to send it off for a sensitivity and specificity, so we know exactly what antibiotic we want to use. So bloods and imaging. So what else we can do? We can do a blood culture. In about 20 to 50% of cases, there might be septicemia as well, so the blood culture might be helpful. We want to do a full blood count, CRP and ESRs, just checking for raised inflammatory markers and leukocytosis. X-rays, well, hopefully you've caught it early and they're presenting acutely, so you might not actually get many changes on X-ray, but if it's a more chronic condition, we will be seeing soft tissue swelling can be present early on, but like gas within the joint, synovial effusion, loose bodies, more like classical signs of like sort of bony erosion as well. But that's only if it's like probably progressed quite a bit. And then ultrasound, we're seeing similar sort of things. So the joint effusion, a collection, maybe some loose bodies, and inflammatory changes in the tissue. But overall, like if we're catching it early like we want to, we might not see a whole bunch of changes apart from extra fluid and swelling. So treatment. So general supportive care, we'll give analgesia and IV fluids. Then we're doing this arthrocentesis also as like sort of therapeutic. We want to try and get all this gunk out of the joint as we can, and one of the ways is through the needle. Then if we are more worried, we'll do a surgical debridement where we open the joint up and we completely wash out all the infection and scrape it off the bone. We may also, if it's a prosthesis, we might do an exchange arthroplasty where we're removing the infected prosthesis. And this can be done in 1 or 2 stages. So obviously in the one stage, we're yanking it out, putting a new one in. But in a 2-stage process, we are removing the infected prosthesis, giving it time to sort of heal and clean itself out before we're putting a new one in. And that will hopefully lead to better outcomes. And then we're giving antibiotic therapy as well. I'm not the best on antibiotics, but these are some general rules that if it's like a gram-positive cocci, we want to use a cefalozin or a flucloxacillin, which I'm butchering, unless it's MSRA where we're giving vancomycin. If it's a gram-negative bacilli, we're going to give them a cephalosporin. If nothing goes, we're going to have to use a bit of our clinical judgment. And just a fun fact, injecting antibiotics into the joint doesn't really do much. All right, and this is like a good joint aspiration. So you can see we've got that lovely, tasty yellow fluid. So that's not like a good thing, but a good thing that we're getting it out of the patient. And then complications. So in the States, if a patient is hospitalized for their septic arthritis, there's a 3% mortality rate. So it is quite a serious condition. 1/3 will need major surgery, including amputation, arthrodesis, which is exchanging the prosthesis, prosthetic surgery, or they'll have severe functional deterioration. Joint destruction is ultimately if it's untreated. And this is due to the inflammatory fluid that builds up in the joint, leads to an increased pressure, which compresses all the blood vessels in the joint, leading to necrosis. You can see on the x-ray on the thumb, you can see the joint there is beginning to erode, which is not good. Osteomyelitis can also be a complication, sepsis, and if it's an issue that we're seeing in children, we might have growth arrest and issues with their normal bony development. I used all the standard medical student resources, so Radiopedia, Up to Date, Amboss, Osmosis, and Wonderful Word of Orthopedics, and that's me.